panel discussion on inpatient glycemic management. For that, the moderator is going to be Dr. Anand Moses, sir. I request all the other panelists, Dr. Joseph Pannirselvam, Dr. Ramanan, Dr. Amala Florida, and Dr. Bharanidharan to join.
So, good afternoon, everyone. We now come to the panel discussion. That is little different. We are not going to have any slides, and you cannot sleep also. So, because the lights are going to be on. We have because it's a very common topic all of us face day to day in the hospital. People working in large hospitals, I think people sitting here all are working in big hospitals. This is Dr. Bharanidharan. He's a physician diabetologist from Kaveri Hospital. Dr. Joseph from Trichy Maruti Hospital. That's what I said, all are from big hospitals. From the biggest hospital, Triple M, we have Dr. Ramanan and Dr. Amala from VHS. So all are working in hospitals where there are inpatients and they manage hyperglycemia. So first, Bharani, how often do you see hyperglycemia? I'm not telling surgical. I'm not differentiating between surgical patients, medical patients. In the hospital, what percentage of the patients admitted have some degree of hyperglycemia?
Thank you, sir. So actually, this is a very good question because nowadays in hospital, I work in a tertiary hospital where we are seeing more than 60% of the people are diabetes. So when you check patients coming from emergency room or getting admitted for the hospital for various surgical things or any medical managements, so more than 60% of them are having a hyperglycemia. That is a value more than 140. So that is what we are adjusting, and even the number is keep on increasing nowadays.
60% is a very huge number. What do you
Mostly, as I said, 60% of the patients
because once they come to the hospital, they come with some problems, some morbidities. So most often it is associated. So it is an important thing to diagnose. There are 2-3 aspects in hyperglycemia in the in-hospital patient is one, a known diabetic coming for admission. We all know. Suppose the patient is not a known diabetic. How are you going to screen for Dr. Joseph?
Yes, sir. So we used to screen for diabetes for each and every admission if the patient age is more than 30 or 35 years, because nowadays we are seeing more and more number of young diabetic patients. So sometimes the patient may not be having symptoms. So for all the IP admissions, so it's better to screen for diabetes. If the admission blood sugar is more than 150, random blood sugar is more than 140 or 150, it is better to go for fasting phosphatidylcholine sugars along with the HbA1c. And if the patient is having risk factors also, such as obesity and other comorbid conditions such as hypertension and other things, so it's better to screen for, because we can detect more number of asymptomatic cases.
Yes. And Dr. Ramanan, what is the role of doing a HbA1c in a admitted patient?
That is very, very important, sir, because I work in a cardiac center where...
I'm telling a non-diabetic patient who has come to the hospital. As he said, he has detected hyperglycemia of more than 140. Is there any role for doing a HbA1c in that patient?
Because we have seen many patients coming with hyperglycemia, even their HbA1c is even 5.5. We tell us stress-induced hyperglycemia. Or infection, sometimes because of the infection, there will be rise in the blood glucose levels. So managing that hyperglycemia is very difficult for us, because we know, for example, if the HbA1c is more than 8 or 10, we know we can start our infusion or a basal bolus regimen based on the patient scenario. But when the patient HbA1c is within the normal limit, and if sugars are more than 300 or 350 or 250, we have to go little bit slow when compared to a diabetic patient. So HbA1c is very, very important, along with other parameters.
So what is message HbA1c gives? Suppose HbA1c is very high, but you have detected diabetes for the first time.
Two things. A patient may
Undetected diabetes.
undetected, or
Then-
the patients are on diabetic medication, they may not have a regular follow-up with the doctor, and they may not take
And it has
medication.
been shown that outcome in the hospital
Yes, sir.
worsens as the HbA1c increases
ISI.
at the time of diagnosis.
The post-operative care or the hospital stay also increases on the HbA1c in the ISI.
So even more than 6, they say anything more than 6, there is a linear increase in morbidity and mortality as the first HbA1c as well as the first sugar on admission. Dr. Amala, you can talk something on stress hyperglycemia and its importance.
Yes, sir. So we see a lot of stress hyperglycemia in trauma patients, even patients who
Now, how
come-
do you screen for stress hyperglycemia?
Yes, sir.
How do you diagnose stress hyperglycemia? What is the importance of that? And do you treat stress hyperglycemia?
So we have to treat stress hyperglycemia, but it's all the more it's important to differentiate whether it's newly diagnosed diabetes or it's a transient stress hyperglycemia which is going to settle down. So the latest guidelines, they say, like if we find 2 consecutive random values of more than 180, so it's imperative to do a HbA1c for that patient. So the HbA1c is more than 6.5, so that patient can be classified as already who has been a diabetic. So that's not stress hyperglycemia. So if the HbA1c is less than 6.5, it's very likely that this present hyperglycemia could be a stress-related one, and which would settle. And maybe in another periodically we have to keep the patient under monitoring. That's what the latest guideline says.
But do you treat that stress hyperglycemia? Suppose the HbA1c is only 5.5 and the blood sugar comes as 220, 250. Do you want to wait till the stress comes down, or do you want to treat that stress hyperglycemia? Depending on some situations you can give. Suppose it's an acute myocardial infarction or a road accident. I think people also can give you your points. Parandaman, yes. Can you give a mic to Parandaman?
Because the problem here is, as Sir said, HbA1c 5.5, blood sugar is 250 or 300. That shows is not a diabetic, that shows what for which he got admitted is severe. The disease is severe, not the diabetes severe. For which he got admitted, that is severe. That means the mortality will be very high for them. The person who has a high HbA1c, high blood sugar, no problem. As usual, you can treat. But person with a low HbA1c, high blood sugar, the disease for which patient presenting is severe. So like I said, like MI, that shows severity. Suppose poisoning. Higher the blood sugar, lower the HbA1c, complications more. Mortality is high. That's what probably
Yes,
that's why
that's the message what we get from stress hyperglycemia. Yes, sir, you want to? Sir, stress hyperglycemia, suppose there is stress hyperglycemia, the HbA1c is only 5.5, blood sugar is 250, 300. That shows that the underlying disease for which the patient is admitted is severe. It is severe enough to cause a counter-hormone response and leading to hyperglycemia. And it also affects the outcome. And there are a number of studies. If you look at a number of studies by Vandenberg and others, they have shown that a linear increase in the morbidity and mortality as the blood sugar goes up, even in a person with a normal HbA1c. So, measuring a HbA1c is not only for control of diabetes. In the in-hospital setting, when a patient comes for the first time to the hospital, when you do a random blood sugar, always do also try to get a HbA1c done. Probably it will, yes sir? Prognostic value. Yes, value. And you will know, suppose the patient is already, suppose the HbA1c is 9, 10, that means you know that he has already probably a severe vascular disease already underlying. The prognosis may be better if the HbA1c is less and or a newly diagnosed diabetes. So it gives a lot of information. Yes, Parandam.
One more reverse is also there. The person admitting for a surgery, HbA1c is 11.5, the blood sugar passing is 100% will 140. Again, complications more. The HbA1c indicates there is a glycogen of all proteins, everywhere, all glycogen proteins all over. But here we are measuring hemoglobin only, so glycogen hemoglobin. But protein are all every protein has got a glycogen. So the complications are more with them. So higher HbA1c, control blood sugar, immediate that means they control with the insulin or short time.
Short.
But the complications because heart muscles are already glycogen with the proteins, and the complications you expect more. So you have to be controlled. If you really want to get a good outcome, control diabetes for longer VOC and HbA1c are higher, then the mortality.
COVID was a classic example for that.
Yes.
Sir, one more point to be added. You have to ask in the history whether the patient's on steroids.
Steroid. So we are coming to that special situations. Special situations like acute MI, steroids, a post-operative condition. Sir, what should be, Bharanidharan, what should be the target? Suppose you have diagnosed a hyperglycemia and you are going to treat. Before you start the treatment, you must have some target in mind. What would be a target blood glucose? Because we cannot have a inpatient, you cannot have a specific fasting postprandial appdi varadu. So you must have some target for your treatment.
Yeah, actually, the target we keep is a 140
And you
to
can quote some
yes.
guidelines like the nice sugar guidelines.
Yes, nice sugar guidelines is very important because, as I said, because previously Vandenberg trial they have given as a strict glycemic control that is causing more hyperglycemia, more damage. Then what the nice sugar guidelines came that shows 140 to 180 is the cutoff we can just maintain to prevent any complications. Because keeping it very low, that hypoglycemia will cause more damage than keeping it in 140 to 180. That is the acceptable range in the in-hospital management glycemia.
All of you are agree with that, Ramanan or Paneer?
So it depends on the setting of the patient, whether that patient is in critical unit or non-critical unit. So critically ill patients, better to keep the blood sugar levels between 140 to 180. That's what the guidelines say. For non-critically ill patients, younger patients, so we can aim for stringent controls, more stringent controls, so that without causing hypoglycemia, so that so the outcome would be better, sir. Better, sir. So here you can relax from 100 or 110 to 180 would be the optimal level for non-critically ill patients. But critically ill patients, better to maintain between 140 to 180. So that's what guidelines say, sir.
So how often do you want to, in the critically ill patients, how often do you want to monitor the blood glucose
It's
level?
based on the patient, critically ill patients you're talking about.
Yes, he talked about it. We'll take one example as a critically ill
A
patient.
critical ill patient, usually, we consider when the patient is on ventilator or not able to eat anything. In such patients, we tend to put them on insulin infusion as
Yes.
per the criteria.
No, we will come to the treatment later. Monitoring.
Monitoring is based on the scenarios. It may be half an hour or hourly sugar checkup or secondary sugar based on the patient's
Based on
need.
the patient.
Or even nowadays we use CGMS also.
Yeah. We'll come to the next. Is there a role for CGMS, continuous glucose monitoring, in the in-hospital setting? Amala.
Yes, sir, but nowadays the recent guidelines, they have approved a role of CGMS. So patients who have already been on CGMS, we can very well continue the use of CGMS even after they get admitted. But during admission, it's not highly recommended to start a CGMS, to fix a device for the patient when the patient is admitted in hospital. Another thing, so we have to make sure technically the device is okay and all those technical aspects are there. And it's always better to correlate the CGMS values with a pinprick, with a capillary blood glucose value. And there should be a sound diabetes care team to take care of the CGMS.
What is the...
So actually CGMS, because nowadays we started using continuous glucose monitoring study because there is the advantage of even real-time monitoring also. So especially for the post-surgical patients admitted for CABG outcome, the glycemic control. So even actually we just initiate CGMS, even after the discharge we can real-time monitor the sugar level. So the outcome of any surgery is the glycemic control. So keeping the glycemic control is important. So transition, there is a paradigm shift in diabetes management is happening. There is a role of nowadays artificial intelligence and machine learning is coming. So we have to adopt to that. Accuracy point, yes, definitely the FDA is also nowadays the recent guidelines also showing that CGMS can be initiated. Already patients, especially type 1 diabetes patient who is on CGMS, definitely we have to just continue with the CGMS.
No, patient on CGMS,
Yes.
we say continue. Can you start a CGMS in the hospital for
yes,
monitoring?
it's individualized. We have those patients who are having high glycemic variabilities, definitely we can consider. So it becomes a challenge for both the patient and the physicians. Those kind of patients we have to select it, not for every patient. Right now, we can select the patient, choose the patient, which kind of patients will be ideal for CGMS.
Is there a time lag in the real-time blood sugar and the CGMS? Ramanan.
Is there?
Huh?
Is there?
It is not the
It's
real
not that
time.
calculating.
What you are seeing in the CGMS is in the fluid, interstitial fluid only. So there is a time lag about 15 minutes. 15 minutes time lag between the blood sugar and the CGM blood sugar. Is it going to affect the treatment in any way?
May not be.
May not be much. It's
Actually, the CGMS in critical care is not advised as of now, even though it's useful, because patient will shock. Patient are adrenaline, non-adrenaline, because most of the patient is shocked and they will be having. So when the shock is there, the glucose sensor will not be properly recording. So if they saw high value, low value, so it's a problem in especially critically ill patient. But in the hospitalized patient, yes. In the brittle diabetes, where the fluctuation blood sugar is there, where you need to have post-surgical, but not in shock. No, and such individuals probably controlling blood sugar less than 200 is ideal, and especially if we more than 210 in post-operative, it inhibits the glucose function. Glucose function, the sepsis will be more. That's why the post-operatively, first 1 day, you have to keep it blood sugar less than 180. Otherwise, the inhibition of the neutrophil function, that is component to the sepsis. That's the one recommends. But nowadays they use. Nowadays they are using.
yes. Though there is a time lag of about 15 minutes, yes, someone is asking.
Yes, actually, very good question. Because actually, in area 2024 itself, they have just done studies in COVID patients. So by the time only they started using the CGMS. Actually, mild to moderate severe patients in CGMS, they are with the CGMS they can able to monitor the glycemic control, and then they can able to things, especially sepsis patients. After that, only the consensus statement about the CGMS becomes more powerful, because they used the CGMS in highly sick COVID patients. So yes, definitely we can use it febrile patients, because febrile patient is very important. They may go for a hypo and hyper depending upon the gram positive. So ideally we can use CGMS for those patients. There will be more fluctuations are happening, and during this phase, if we control the glycemic level only, we can able to manage. Not alone the antibiotic, glycemic control is very important. Especially such a kind of diabetic foot ulceration patients, they come with high fluctuations sugar. So once we treat glycemic level with a good antibiotic, the outcome will be good. Definitely we can use the CGMS for this kind of patients.
Does CGMS warn of hypoglycemia?
CGMS?
Does CGMS give any warning about hypoglycemia?
Actually, now they came with the real-time CGMS.
Yes.
So they have the alarm system also. So it just gives us warning signs to the patient also. And even the treating physician, they can get the signals. Now the technology is adopted. Once, yes, it can be
Steroids,
used.
yes,
Yes,
definitely.
definitely, we can just use it.
So, yes, Parandaman, you want to say?
Yes, because we see day-to-day practice, we have seen that different patients, actually my point of view is, febrile patient with the diabetes, you control the fever first. That is priority. Sugar is not the problem. When you are able to, suppose a septic focus there, abscess is there, you drain the abscess, sugar will come down. So you need not have a continuous blood glucose monitoring for that individual, because see, they identify the problem. And sometimes they may have insulin resistance due to sepsis. So all IL into cytokines, all cause insulin resistance can have temporary. It's all temporary. It's not going to alter much, especially sepsis patient. And viral illness is not going to alter much. Only those who are on high dose steroid or on post-surgical tissue destruction, those individuals, when you are not able to because we have basal bolus, or we can give, whenever you give subcutaneous insulin, every 4th hour is ideal. If you are an IV insulin, ideally every 1 hour, but we generally, because cost effective, every 2 hours, very practical. And such individuals, you can give every 4th hour, you give blood sugar and give insulin, short acting, very simple. But when you have a really post-operative state where the high blood sugar, then probably you may require CGMS. Is absolutely a very practical difficulty. The solution is is a candidate of type 1 diabetes. There is no question about using continuous blood glucose monitoring in type 1 diabetes, especially in a situation like this. We are talking about type 2 diabetes where the insulin resistance are high and fluctuation of blood sugar is there. In those situations, probably you can use, because already type 1 diabetes continuously you need to give insulin, continuously you need to give it, continuously you need to monitor. That is nothing wrong in it. For type 1 diabetes, no question at all using continuous blood glucose monitoring. I'm talking about the adult individual getting admitted in ICU where the recommendations, because I was preparing for a lecture, I was referring to all the codes, and they said it's a critical care, probably is not recommended now, but still it will be useful. But that again depends on the patient condition, physician's discretion.
Sir, but inpatient even in type 1, is it validated as CGMS?
No, not type 1, it says critical complication.
No, he's talking about type 1 diabetic.
Fluctuation blood sugar. He says about fluctuation blood sugar, 500, 700.
Validated sir as inpatient? Do we have data to say that yes, we can use CGMS for...
Current recommendations are not very strong in inpatient setting.
Inpatient settings, we don't have recommendations even for...
As Dr.
In type 2, there are recommendations which were.
Also, we don't have as inpatient, sir, but though some people are using like...
No,
sir is using a lot.
No, even the ADA latest ADA recommendation, latest ADA recommendation says in type 2 diabetes we could use CGMS in non-critically ill patients.
Non-critical illness, their recommendation is this.
Yes.
Non-critical illness recommendation is there. Critical illness not level A, but all this thing, your short acting 4th hourly blood sugar, 4th hourly give insulin, that's sufficient. Any short acting 4th hourly, you prick it and small dose till the acute crisis is over. Once it is improved, then probably basal bolus, then subsequently.
Dr. Joseph, in a critically ill patient with shock, is there any disadvantage in using a capillary blood glucose?
Yes, sir, sometimes it can cause variation, sir. But at times we will be left with no other options. So the point of care testing is commonly performed. So if needed, it depends on which regimen patient is on. So if the patient is on continuous IV insulin infusion, we have to monitor often. Probably every 1 to 2 hours you have to monitor blood glucose levels. And if the patient is on subcutaneous insulin, probably every 6th hour, before every meals and bedtime, we can monitor.
No, the value of the sugar.
Yes, sir, because of the hypoperfusion.
Hypoperfusion in
The
the
capillary
peripheral tissue.
values won't be that reliable. So we have to always correlate with the venous laboratory.
Venous
value.
or in this situation, probably a CGMS may be useful. That is what is given in literature, where the patient is in shock, where the peripheral vessels are constricted, where the capillary blood glucose reading may not be very reliable. One alternative is to use or do a frequent plasma
Laboratory,
glucose.
venous testing.
Yes. How many of you are dealing with total parenteral nutrition in hospitals? Ramanan.
Most of our patients are on.
TPN, how do you monitor and how do you?
Sir, we follow in 2 steps. There are 2 types
It's
of...
very simple.
Yes, sir.
Broad outline. We did
Okay,
not.
continuous infusion plus a bolus short-acting insulin before each meal. That will be ideal. So that
Bolus is given subcutaneous or intravenous?
no, subcutaneous.
Subcutaneous.
Not into.
For every 1 liter of fat,
Yeah.
20 units of short
1 unit of insulin for every 10 grams of carbon.
10 grams carbon, that is the thing, routine for total consultation.
TPN, it is different. You have to give correction dose in between.
Again, after 2
units in each
liters.
you give, that will suffice. And in addition, if extra insulin is there,
It's that is what we'll do, sir. That is what we'll do, sir. And what I prefer is after 2 hours of starting insulin, after starting feed, again we check the sugars and we give correction insulin. That also to make the sugars.
Is there a role of for a basal insulin in the acute care setting?
Yes, sir, definitely there is a role, sir, because if you see the normal physiology, so the basal insulin is released constantly. So even if the patient is not eating, like in diabetic emergencies, so we need to give basal insulin, provided, so we have to monitor. So the patient should not go develop hypoglycemia. So there's a definite role for basal insulin, sir.
Yes, all of you agree?
Yeah. And nowadays, the latest recommendations say even when the patient is on an infusion, you
Infusion
can
is given.
simultaneously put them on a basal.
I think the concept has changed a lot. About 10 years back, we were saying once a critical ill patient, it is only a short-acting insulin frequently. But here, the glycemic variability becomes very high. We use only short-acting. There are wide fluctuations in blood sugar when you do a CGMS. And there are a number of studies to show that if you give 40% of the insulin requirement as basal insulin and top up with short-acting insulin, even in a critically ill patient, even in an ICU, you could use a basal insulin where you can reduce the glycemic variability as well as you can get a good control.
And even while stopping the infusion, previously they were, before stopping the infusion, they were giving only bolus. So nowadays the recommendations say a basal also can be given some 3 to 4 hours before stopping the infusion.
So we are all used to Lantus for a number of years, but now I think Tresiba is taking over. I remember only the brand names. Glargine or
Glargine is still the most commonly
most popular.
used.
All of us are used to using Glargine in the ICU. That's what I recommend for my patients.
Degludec is slowly...
Slowly, Degludec, probably it's a marketing strategy or something else, we don't know. Long. But you can give a smaller dose, sir. Once you have a basal insulin, topping up becomes easier, as Joseph said. Once you have a basal insulin,
In acutely ill patients, titration becomes difficult, sir, with Degludec. Like Dr. Pratish was mentioning, the girl who was on Fiasp and Tresiba, maybe that also could have been a reason. The titration becomes very difficult with Degludec.
Ramanan, acute MI, in a situation of acute, you see a lot of acute MIs in your hospital. How do you manage hyperglycemia in the first 3 or 4 days in an ICU?
Based on this scenario, the patient is blood sugar hyperglycemia. If the patient is taking food normally, and we continue the OHS.
Continue OHA.
Continue OHS. That is what, but many hospitals know they'll stop OHA.
I think
But we continue OHA.
I think we'll stop here now and get the opinion of
We
the.
continue OHA. The patient is stable.
Okay.
And he is not on any support. We continue OHA.
How many of you agree with that? In an acute MI, the first 3 days of acute MI, will you continue oral drugs along with insulin or stop oral drugs and go only for insulin? See, Lakshmi, what do you do in your hospital? Do you stop insulin or stop oral drugs in acute MI or continue oral?
no,
What oral drugs do you continue?
Only gliptins.
Gliptins. Sulfonylureas?
No, after 3 days sulfonylurea definitely. Because the patients who are on 4 milligram sulfonylurea, if I put the patient on insulin, it is very difficult for us to continue control the blood glucose levels as per the criteria to get the HbA1c, the blood glucose less than 200.
You go for a basal bolus in.
Yeah, even though.
Yes, yes, madam.
We can use ASG.
No, we
we
see
can
all that everything is stable, we continue OHA. If the patient is not stable, we'll stop OHA. I'm not saying for all the patient I will put OHA.
But your patients, when they become unstable, we don't know. Suddenly they become unstable.
No, sir. After 2 days, 3 days, we start
3 days
OHA.
after.
Not on the day of admission. After 2 or 3 days, anyway, when the patient shift to step down ICU or ward,
Then it's acceptable. I'm
after
telling
2 days
during.
I'm talking, not on the day of admission. But I don't know. You all.
Yes.
Yeah, Manoj.
Manoj.
Yeah.
Or we will go with basic bolus therapy. Once the patient gets shifted to wards, then we start with the OHS.
So that is acceptable.
That is what we are.
No, that is what he is trying to tell. Actually, for
Acute-
stable patients.
Not on the day of admission, madam.
Yes.
So
So he understood.
We understood in a different way.
Yeah, yeah, yeah. Madam?
Depending upon the year, if the patient are SGLT inhibitors, like do we have to adjust the dose of insulin?
Yes,
Madam,
definitely.
Yeah, definitely.
Definitely.
But in acute, we will not start an SGLT2 inhibitor. No. Only after 2 months, we will start the patient on SGLT2. We can.
So when you are talking about SGLT2, what is your opinion on using SGLT2 in critically ill patients?
So,
Do you, if the patient is already on a SGLT2,
So
in a
the-
critically ill patient, would you like to continue or?
so the current recommendation is, the current recommendation better to stop SGLT inhibitors in critically ill patients, sir, unless patient is having cardiovascular, atherosclerotic cardiovascular disease,
Atherosclerotic or heart failure?
heart failure,
Heart failure.
so it provides mortality benefit. Otherwise, it's better to stop it because it can cause various disturbances like volume depletion can be there, electric disturbances can be there. So it's better to stop in critically ill patients. So later on we can restart it. So if required, we can restart later.
But what I feel, no, sir, all cardiac patients, no, after 2 months of their, put them on SGLT2, they feel better. And many patients, quality of life is drastically improved with SGLT2.
Yes, sir, absolutely agreed, sir. Because it's almost like a diuretic. Because
It is a diuretic.
Sir?
Diuretic effect is there.
it is because glucosuria, sir. Glucosuria, when glucose goes, sodium goes, sodium goes, water goes. So that is the diuretic effect is there.
Yes, sir. Yes, sir. When we start on SGLT2, cardiologists will reduce the dose of Lasix or Arlectin, whatever they are taking.
And also it increases the contractility of the myocardium by its own inherent vasodilator and by increase the glucagon. Glucagon one is supposed to increase. The glucagon is the one that increases the contractility of the myocardium. So thereby it increases the pumping of the myocardium and increase the letting out of the sodium goes, water goes, and the other benefits like vascular benefit, and especially chronic heart failure, stable patient is very, very useful. But in acute failure, euglycemic ketosis is the problem. Once euglycemic ketosis comes, then again acute complication. That's it.
Yeah, Manoj.
Yes, sir. We have used, actually in our setup, we have used SGLT2 inhibitors even on the day 2 of admission for heart failure.
Heart failure is
Yes, that's acceptable.
Heart failure is
Yeah,
acceptable.
yeah, yeah.
Euglycemic ketosis is the one concept that is acute ICU. If it develops, then you won't be answerable.
We have not got into this one. What we see, sir, actually in our hospital, we see global longitudinal strain. That is between -18 to -22. For patients whose GLS is less, let's say like -7, -6, when they are put on SGLT2 inhibitors, the global longitudinal strain
Improves.
Even EF doesn't improve, even the GLS starts improving. And that is a sign that we should be using it for a longer period.
Let's agree. All these beneficial factors are there on the heart and kidney. Only thing, always an acute problem. The only thing is acute euglycemic ketosis is the problem. When patient is in ICU, when you are using SGLT inhibitor for this purpose, then when complications, you are answerable.
Sir, put a small dose of insulin. Sir, that will
Yeah,
make
yeah.
No, why does euglycemic ketosis comes? Because you are producing ketones, you can blend it with the insulin.
Insulin.
So that effect is taken care
With
of.
gluc-
You should be worried even on the second day, third day, fourth
After
day.
it's longer. If you use SGLT inhibitor 20, 2 weeks, it will be the ketogenic effect. 2 weeks
That
ketogenic
is okay, sir. It is only because of the ketones that the heart is regenerating.
And recommendations should agree.
Sir, we have data, sir. It has been used for
You
Sir,
give
sir, one point.
glucose and insulin.
See, many cardiologists in India, before the recommendation comes, they started using SGLT2. If I am not wrong. Many cardiologists in India, they started using SGLT2 in the heart failure patients, even the recommendations out. Yeah, even in non-diabetic, yeah, in our hospital we use, because we...
Used a smaller dose initially before this Emperor study was published. We are using in non-diabetic, but a smaller dose.
It's personalized data.
Yes.
But when you're you should be accepted.
EMPA or DAPA. See, if the patient wants a weight loss, I'll use EMPA. The patient doesn't want weight loss, maybe 2 or 3 kgs, okay, I'll use DAPA. If the patient don't want weight loss, then remogliflozin will help.
It's only so you are going to the least effective.
At least. Because there are patients, no? See, yeah, but empagliflozin drastic weight loss, sir, when compared to dapagliflozin.
You must understand, all patients will not be total responders. There are non-responders. I have used in many patients, no weight loss, but gain weight. What are you going
Yeah, I have seen patients who gone way.
Sir,
gone
each
weight.
patient is different. We cannot generalize the whole thing. See, Barney, can you give some simple insulin protocol which you follow in your hospital?
It's actually everywhere globally accepted is a basal bolus insulin regime. That is a very simple protocol.
Yes.
we follow.
What
That is
about IV protocol? Anything? Any?
So it actually IV protocol we.
Do you use a sliding scale to adjust the?
Yes. So the thing is
adjust the dose of insulin.
No. So it is not the proper way of treating diabetes. Always, whenever comes to the most of the time, this sliding scale is like chasing the number. It's not a proactive thing. So it is just treating
If you
the
are
numbers.
not using sliding scale, what else will you use?
So we use actually basal bolus, and then also we can use a correctional insulin depending upon
No,
the
if a patient
patient's,
is on IV.
So IV. So IV insulin, actually we use insulin protocol, it is individualized for the patients. We should have a hospital protocol. So because there are a lot of protocols globally, that is not fit to the things. Yes.
So, but what do you instruct your staff in an ICU? You are not going to sit the whole time in an ICU. You have to give some instructions to your staff. Patient is on insulin infusion. We have been, all along, we have been using the,
Sir, but the RABBIT-2, sorry, sir. There's the RABBIT-2 study which compared the sliding scale and the basal bolus regimen, and this basal bolus was found to be superior.
sliding the scale, they say you are treating the sugar after it has gone up.
Yeah, we are chasing the sugars literally.
But what else instruction can you give to the ICU staff? I think the sliding scale, still there is some role for sliding scale. That's what I.
So it is actually not
Modified, we can say modified sliding.
Modified sliding scale. Yes.
The difference between the sliding scale and the basal bolus is what? We use basal.
No, we are talking about insulin infusion. Patient is on.
I think that for insulin
infusions.
no size.
IV insulin infusion. Yes, that is
Blood sugar divided by 100. If blood sugar is 100, 500, you divide by 100 is equal to 5 units. 400, 4 units. 300, 3 units. These children start you more than 500, you 5 units. 400, 400, 300. So they use to call it. Every 2 hours you monitor, you bring down. As the blood sugar comes up to 200, you stop it, give you
5 units per hour, is it? 5 units per hour. That's a heavy dose.
But
so when the patient comes with the glucotoxicity.
yeah,
we
but
use,
we should think about glucotoxicity of the
Yes,
patient
that's what,
also, because a thin patient may sometimes no, we think thin patient may not require such high dose of insulin, but the patient comes with such as sepsis or high glucotoxicity, he may need more insulin also. So, and some patients, even if we give 5 units for 1 hour, sugars may drop down. So maybe start with low dose. That is what I think. What do you say?
Yeah, actually, patients comes with the DKA with the high sugars. Patients in a glucotoxicity go with a high dose of insulin infusion. Gradually, within 24 hours to 48 hours.
So monitoring is the key.
Yes,
So that is important.
That is what the thing.
Monitoring is the key. Whether you use high dose or low dose.
It depends upon.
Without monitoring.
Yes.
see whether you keep monitoring, maintain the blood sugar around 200. Keep monitoring frequently. That is the success of the management.
Sir, if you want, one question, sir, to you.
Still, Parandaman, still it is some sort of a sliding scale only.
Yeah. The modified sliding scale. Sir, for example,
So
a
only
patient
for
comes
acute
to you
phase,
for
definitely we can
450,
just,
you start immediately a sliding scale, or try to give a subcutaneous, wait for an hour, or
Sir, I think that
Yeah.
the terminology is not a sliding scale, it's called a correction dose.
correction.
Yes, you can change the terminology. That's all.
If the patient is on infusion, sliding scale doesn't apply.
Sir, for your question, sir, simple. It's actually very practical question.
Ah.
So blood sugar is coming at 500. Sir, see, this is a practical difficulties we face in day-to-day practice. Blood sugar is 550. Dr. Raman is asking, will you start 5 units per hour immediately? Even though that's there, we don't start. We'll give 10 units of short-acting insulin, just give subcutaneously, wait. see the response. If the response is there, continue with the subcutaneous insulin every 4th hourly, keep giving monitoring. If not coming down, start IV. That's all.
What if the patient's ketones are positive and
No, that is different story. That is different. That is DKA management.
Sir, what will happen, sir, if you give 5 units IV over 1 hour, monitor it after an hour, the sugar, if it controls fine, if it doesn't, you know
See,
the response.
சாருக்கு தெரியும் நிறைய ஹைப்பர் டக்குன்னு போயிடும், டக்கு அரித்மி வந்துடும், டப்புன்னு போயிடும்.
1 hour insulin off like this, IV insulin off like this only 7 minutes. So you stop it then, monitor only every 2 hours. So it is much
I think, are you managing an intensive care? No, see, several times I burnt my finger. Several times I burnt my finger. One patient came, for example, one patient came.
you know,
No, there are
the
lot
first dose of insulin, you don't go by the height of the blood sugar.
Yes.
That is what he says.
Second dose, third dose.
See, what he means to say is, don't go by the height of the blood sugar, your first dose of insulin. How the patient responds to
second
the
and third
first
dose,
dose
start. As
is
you like,
totally
aggressive.
different.
You are aggressive.
So, but there are few studies which say that the subcutaneous bolus doesn't work.
When?
For this much high sugars, subcutaneous bolus is not the solution, at least.
Most of the time they will be in dehydrated state. If you give normal saline from 500 come to 350. So many cases I have seen.
Parandaman, can you use intramuscular insulin in these patients? I think theoretically, the older books used to say, when you do not have an IV access, when you are in a place where there is no IV access, patient is in shock or in ketosis, you could use an IM insulin. Because subcutaneous absorption is not there. Yes, IM. There are some rare situations where you can still use an IM insulin.
So just one point to add, sir. Because
Yes, I think we are running short of time. Just 2 more points to be discussed. One is, we have to discuss something on steroids. People like Bharanidharan who work in a hospital where some transplants are done and others. Your hospital also transplants are done. So both of you can share on, one of you can tell about short-acting steroids. Suppose a patient is on short-acting steroids, what insulin are you going to use and
Yes, sir.
how are you going to monitor that?
Yes,
I think
one-
it is different. Short-acting steroid monitoring is different. Long-acting steroid is different. I think most of you know that. It's very important if you are, particularly if you work in a place where there is transplant or where there is a cancer treatment where large doses of steroids are given. So Bharanidharan,
okay.
where prednisolone, suppose a patient is given a large dose of prednisolone in the morning, what insulin schedule you want to give, how you are going to monitor the blood sugar, which
Yes, sir,
after
actually.
how many hours?
Yes, sir. Actually, one thing we should understand is whenever patients admitted for the hospital, they are not diabetic also. Once they start steroid, you should not think that it is a steroid-induced hyperglycemia. Always patients on steroids, they are getting hyperglycemia. Definitely, we should understand impending diabetes. That we have to just understand. And also, the new onset of we got the NODAT, the new onset diabetes after transplant. That is also after the thing. Those patients also have impending diabetes. How to manage patients on steroid? So definitely, the short-acting insulin will be the ideal things. Whenever there is a peak, definitely we can just use the insulin to correct it. And also one thing I to add, not alone the insulin, we can use oral hypoglycemic agents if the patient is stable. It's not because most of the time patients are insulin resistant. So even more than insulin, they also respond to OHS also. Even we can use short-acting sulfonylurea also can help. But regarding insulin, we can use short-acting insulin for these patients. And though having a long duration steroids, we can add a basal insulin also for these patients.
The peak action of your short-acting steroid comes in about 6 to 8 hours.
Yes, sir.
Yes.
So that's why, so that we can give basal insulin in the mornings along with.
Yes, that's what I wanted, answer I wanted. NPH, for a patient on prednisolone, you give a NPH insulin in the morning. So NPH has a peak at around 5 to 6 hours. So that it is good, NPH is good for patients on prednisolone. You have a short-acting insulin. Along with this, you use the old NPH insulin, which has a peak at 6 to 8 hours. Probably your peak of prednisolone action you can control with that.
For example, the patient is on long-acting steroids, like dexamethasone
like Dexa.
and methylprednisolone, so the blood sugar elevation will be very high. So in such a situation, we need to use
Lantus,
Lantus along with the basal bolus regimen would be better. So in such a scenario, Lantus would be the better option instead of.
Use a basal plus regime kind of.
Basal plus.
regime. That is.
Some of them might require infusion as well, so people who are on methylprednisolone.
Yes, yes.
So if you like to use OHA in such patients, you prefer sulfonylurea or D4 inhibitor, which is
Sulfonylurea actually, because short-acting sulfonylurea will be like a repaglinite also will be helpful, especially the duration is short, and especially patients on steroid, they respond well.
but as the peak will be after 5-6 hours.
Now I'm talking about the short-acting
Short-acting
sulfonylurea.
insulin. Okay.
Yes, that is the thing. That's
So
Yes.
at DP4 inhibitor, okay.
So regarding the steroid, no, we are using steroid daily now for the patient in ICU. Most of the time, post-prandial glucose will be high. Fasting is low. Sometimes fasting is 70, 80. But post-prandial 350, 400. To give medicine for this, if you go, again this will go. That's a problem here. As you rightly said, short-acting insulin better. But some individuals only fasting continue to be high. It varies. It is heterogeneity. It varies from person to person. But most of the time, post-prandial excursion is higher with the short-acting insulin. And dexamethasone, if you consider the hyperglycemic effects of the steroids, dexamethasone is slightly lesser than the mineralocorticoid drug like activity, the methylprednisolone and hydrocortisone. So this means you are using it. But anyway, it's very, sir. We are not able to predict in that way, sir.
Sir, this is you're talking in a ICU setup or in an emergency hospital. I got a very practical question. A lot of patients, outpatients who are on steroids for so many conditions, for dermatological conditions, nephrology conditions, post-COVID conditions, so many things. In these patients, they are given steroids for a period of 3 to 6 months at a tapering dose. In that situation, how will you manage, sir?
Sir, most.
Because there will be definitely hyperglycemia.
Sir, we are going to continue the oral drugs.
Yes.
Definitely they will require insulin. Sir.
No.
Most of them will
No,
require.
no. See, drug-induced hyperglycemia, sir. So, in such situation, what type of molecules would you like to give to control this hyperglycemia in such situations?
In emergency
So
you are
I'll
talking about
answer
or
this
in
patient. Yes, sir. It's a yeah.
it is
I
not
understand.
emergency,
Non-emergency.
normal.
I'll
So
answer
in
that question.
so DP4 inhibitor will
Yes.
be happy because now the sulfonylurea, the chance of hypoglycemia is very high. But DP4 inhibitor, as SAR said, the post-prandial surge with water, the DP4 inhibitor tackle better than sulfonylurea. That is what I saw in the practical.
Yes.
Yeah,
So
I
as
just,
far as SAR
okay.
question is concerned, not all patients with on steroid developing diabetes. Only some people, maybe that's what SAR said, no? Those who are developing hyperglycemia in hospital is not a disease. It is already a pre-existing diabetes or the potential candidate to develop diabetes on steroid, it manifested the high sugar. So because we are seeing a lot of rheumatoid arthritis patients, asthmatic patients and connective disorder patients, they are taking 20 milligram, 30, 40 milligram prednisolone for longer period of time. And not all comes with a high sugar. But only few people, they come with a high sugar, fluctuating blood sugar. Probably again the individual variation is there. The insulin response, insulin secretory capacity of the individual may be better than the steroid drug per se.
Yes. So actually, one thing is practically everybody undergoes because they start with the high dose steroid, tapering the steroid dose, and at that time the management of diabetes will be a challenging. So education is very important, and it is also individualized. What kind of patients we are treating, whether the patient is having a high A1C or a patient is having a euglycemic state, and suddenly they develop because of the steroid. So depending upon the patients, the dose can be fixed. So we have to monitor closely, and we have to first trial and error. So how they respond. As such, we can use DPP for a sulfonylurea depending upon the patients. How they respond, definitely we can tell the dosage for the individual.
So since it's not an emergency, patient may be tried on oral drugs. As he said, DPP4 or a combination of DPP4 and sulfonylurea. They do not respond. We can always top up with the small doses of premixed
I
insulin.
usually use OHA with basil, sir. So the risk of
Basal.
hypoglycemia is also
Or even
less. Also.
the
Patient may go in for diabetes or may not go in for diabetes because
only monitoring, sir. Only.
drug-induced hyperglycemia. So once
Sir, any hyperglycemia, whether drug-induced or stress, has to be treated.
patient may go in the future get for a diabetes
Yes.
or may not go in for diabetes. So in this short period, we suggested to give a DPP4 inhibitor.
No. Only when there is say he says there is no hyperglycemia. அப்போ ஒண்ணு அப்புறம் எதுக்கு?
He is put on steroid for some purpose.
Only monitor. Only.
The later date we have to confirm if he is gone for diabetes or not a diabetes. In the short period of 3 to 6 months, if he has got hyperglycemia, how will you tackle that is my question.
Sir,
I hope I'm clear in my
Yes, sir. You say patient is not a diabetic, but he has hyperglycemia. Yes, but that hyperglycemia has to be treated like a diabetic. No.
3 months or 6 months, what is the molecule you are going to suggest?
A DPO inhibitor will be fine, sir.
That's what I asked.
Yeah, DPO inhibitor
So
will be fine.
after 6 weeks or 8 months or 3 months, you take away the steroids, he's okay.
Stop the drug.
Then stop the drug.
No, you check his HbA1c,
Yes.
check his fasting, check his postprandial. If he is a diabetic, go accordingly.
So, I think we have come to the end of the session. Time was flying. So before we close, a final message. Suppose your patient is on insulin infusion. How are you going to convert the patient to a subcutaneous insulin? Yes, anyone?
Yes, actually patient is an insulin infusion, so we are going to switch over to the subcutaneous. Always we can start 2 to 3 hours before stopping the infusion. We'll start at the basal insulin. That will be the ideal choice. Then we can gradually go for
Conversion, we have to do a conversion. So you have to extrapolate the number of units that the patient has received for the past 8 hours. You extrapolate it to 24 hours. And when you give it as subcutaneous, you give at least 70 to 80% of the total units received as infusion. That's how we convert
after you
to.
give the subcutaneous also, you continue the infusion for 2 hours, 2 to 3 hours, till the subcutaneous insulin effect starts. So there will be an overlap. So there is no rebound hyperglycemia or variability in between. Any other?
We can introduce OHS also.
Yes, you can introduce.
DPP for
Latest recommendations recommend gliptins, and if the patient has heart failure, even SGLT2 inhibitors can be.
Joseph,
So it's better to continue insulin for some time, sir, till the
effect of the subcutaneous.
Yes, sir, yes, sir. It's better. For example, it depends on the indication for the admission. For example, if the patient's admitted for surgery, so till the wound is completely healed, so it's better to go for insulin therapy. Probably we can add OHA along with, so to reduce the insulin dose. We can add DP4 inhibitors with metformin, and later on after the wound healing is completed, then gradually we can taper it, sir. That would be ideal. After the HbA1c, the target HbA1c is attained, so we can.
Thank you. I think I'll thank all the 4 panelists for their active participation.
Thank you, sir.
And I also thank the audience for their interaction.
Sincere thanks to the moderator as well as all the panelists for sharing your wonderful thoughts. And thanks to Professor Parandaman sir also for sharing his inputs.